Mark Urban in Salisbury. Well, to unpick some of the issues raised in that film, I'm joined here in the studio by Katherine Henderson, President of the Royal College of Emergency Medicine, down the line by Nigel Edwards, Chief Executive of the Nuffield Trust, and Professor Derek Alderson, President of the Royal College of Surgeons of England. Good evening to you all. First of all, Katherine Henderson, how long will COVID have an impact on emergency medicine?
It's going to have an impact for a very, very long time. We do not know what the next months are going to hold. We don't know whether there's going to be a second wave, and we're going to have to keep managing patients as though they've got the potential to be carrying COVID.
So the interaction with the patients changes, the amount of time between patients and getting ready to deal with patients changes.
If you think when we went into this, emergency departments were overflowing with patients. We've seen a drop-off in the numbers that are coming through, but we can't begin to have that sort of workload back.
And particularly, presumably, when you once in emergency medicine, you'd have almost patients waiting in corridors. You just can't do that anymore.
We can't do crowding, we can't do corridor care, we can't do people stacked up, lying on the ground as we were getting to last winter.
Derek Alderson, how can you ensure that a general hospital is COVID-free?
I don't think we can ensure that the average general hospital will be COVID-free. I think we can make our hospitals COVID-light, and we can identify places where we can create COVID-light zones. By that, I mean minimal risk of contracting COVID if you go there as a patient for a planned procedure.
And for how long do you think will that be the case?
Oh, I think it will take us many months to recover the situation that we're in with the extension of waiting times and the size of the waiting list increasing. So I think it's really going to be many months because, of course, as we heard in the piece, but patients are frightened, quite rightly, and they need to be reassured. So we need to go through a phase of being perhaps overcautious, proving to people that we can do surgery safely, that you can get excellent results, so that we can have the public confident once again in the services that the NHS provides.
But Nigel Edwards, if you look, at a spanking modern hospital, there's a kind of natural feeling of greater confidence than if you look at some of the old hospitals. And are the old hospitals fit for purpose in a time when we have been dealing with a pandemic?
Well, not necessarily all of just the old hospitals. Some of the hospitals built in the last 15 years often had waiting spaces and corridors contracted to save money. And it's going to be very difficult to make the sort of separation of patients that you really need to have feasible in most of our hospitals, and even more difficult actually in some of our community settings where people visit clinics. So this is a major problem.
Katherine, these hospitals, the older hospitals, where do they tend to be?
Well, that's the worry. That some of our worst emergency department facilities are in some of our most deprived areas. And if you think that some of the coastal towns have got some very old facilities indeed, and those are not designed for managing infection control measures as well as we'd hope. So we're going to have to do something about that.
So, Nigel Edwards, what about the idea of separating COVID patients? The old TB hospital model, is that a possibility still?
Well, I think, as was explained in the report, you have to treat everybody who comes in as emergency as potentially having COVID. So that means people will be turning up at every hospital. And transferring all of the patients who might be COVID by ambulance to sort of the old fever hospital model is just not practical. I was talking to the chief executive of an ambulance service today about this. It's just can't be done. You also have to remember that every time you move a patient in an ambulance, it has to be deep cleaned. And we're buckling under workforce shortages in ambulance services as well as in the rest of the NHS.
So the general throughput in the NHS is going to be reduced?
Oh, very substantially, and not just in hospitals, in community services. Dentistry is a very major worry to me. Their entire business model is completely blown apart by the precautions that they'll be needing to take. And in some cases, you need to leave gaps between patients as well as be cleaning all of the equipment to be able to clear the air.
Derek Alderson, let's turn now to all sorts of different treatments that are not emergency treatments, procedures, screening, cancer treatments. Cancer referrals are down 60% in England. How can you affect change in that?
This is one of our big dilemmas. We believe our modelling suggests that as many as 35,000 cancer operations have not been done. As you say, certain screening programs for breast cancer, colorectal cancer have had to be suspended. So there are large numbers of patients who are inevitably going to present with more advanced stages of their cancer, which means that they will need probably a more aggressive or bigger operation than they would have needed had we been moving ahead with our screening programs. I think the dilemma for treating many complex cancer treatments where patients need chemotherapy, radiotherapy and an operation is we can only do that, those procedures, in our major centres because you need lots of other resources, critical care resources, radiology, pathology, etc. I think for less complex surgery, we probably can make use of, say, the independent sector, which, the NHS has currently made use of. And I think we need to extend that to have COVID-light sites.
COVID-light sites. Where, Nigel, will the burden land? Because what we've had, you talked about hearing little about dentistry, which is absolutely the case, but we've also heard very little about primary care, and GP surgeries are utterly changed and presumably will not change back.
The general practice has responded remarkably well to the crisis and shifted many of its consultations to web and telephone first, and sometimes using video, although actually it turns out the phone is a very effective technology. But there are issues where you do need face-to-face contact with the patient, and video is not good enough for that. You may need to physically examine the patient. So they're going to have issues about needing to reconfigure their waiting areas and their consulting rooms. They have sort of many of the problems of hospitals in miniature, but they have responded extremely well by changing the way that they see patients, and I suspect that that will continue into the future.
Katherine, looking at the job that GPs have to do, essentially they are the first sifters. So they're also going to have to be making different kinds of decisions depending on the capacity of their local hospital.
We need to make it possible for a patient who needs the expertise of a hospital to be able to come up and be safe. We need somebody who's been shielding themselves for 10 weeks, who then gets chest pain and maybe is having a heart attack. We need to make it feel safe for them to be able to come up to my emergency department, know that I will protect them, make sure that we give them the treatment that they need, and make sure that they do not pick up COVID while they're there. But to do that, I need to know that they're coming. So we need to have this concept of heralding patients so that we know that patients who are vulnerable have risk factors if they did catch COVID, which means that we've got to stop them getting it. We need to know they're coming. We need to have space within the department to put them somewhere that is, keeps them isolated and away from danger.
And just turning to doctors and nurses who've been through so much, and we saw that in the film in Salisbury as well. And we saw it in the film that we did in Italy and various other interviews that we have done. What do you think the impact has been on doctors and nurses and the idea of staying on to practice medicine?
There's been a hugely positive impact and a hugely stressful impact. So there's been all the camaraderie, being at the front line, dealing with the crisis, and everybody pulling together. And the amount of multidisciplinary working has been phenomenal, and it has been wonderful. And I hope we never go back to the sort of silo working that we had before.
But that's very interesting about the silo working, that actually this has actually galvanised, in a strange way, the health service.
It's made us go, we've got to get pathways right for the patient in a way that we've never managed to unlock before. We've managed to get a way through with guidelines, we've managed to get conversations going, we've managed to use technology that would have taken ages to get implemented. So there's been genuinely a very positive aspect, but there's also been pretty tiring along the way.
So Derek Alderson, on this question of the whole pandemic, has it taught us anything. As Katherine was saying, procedures have speeded up, things that you would never have imagined before you've done. Do you think this will have a lasting impact? I mean, not just about technology, but on the way people get changes made. For example, as this disease itself has progressed, people were talking about ventilators first. Then they realised actually ventilators weren't necessarily the good idea. Protocols were changed. Do you think this has a galvanising effect in the NHS?
Definitely, definitely. I think that people have, as Katherine says, people have understood how damaging it is to work in silos, how important it is to work as a multidisciplinary and multi-professional team. People have adapted fantastically in the crisis. I think the NHS has been really nimble, and there's a really important lesson to be learned there. And I sincerely hope that we retain that and make best use of it in the time to come, because it is going to be very difficult as we move forward into this winter with the threat of another wave of outbreaks of COVID, flu epidemics, etc., with waiting lists being the size that they are.
Nigel, do you think that the population, and indeed beyond patients that exist just now, people in the future are going to have to realise that, maybe you don't want to use the word rationing, but prioritising is going to be a thing that people are going to have to get used to as they try and work through all the waiting lists, work through all the cancer treatments, that some people will not necessarily get the treatment they need, when they need, or where they need it?
I'm afraid that's probably true. We've got a little bit of a flavour of this in Northern Ireland already, which went into the crisis with extremely long waiting lists. What I think will probably need to happen is that the clinicians across a whole area are going to have to look at who is waiting and find some really good criteria, and also probably talk to the patients about their priorities and goals to work out how to spread the much more limited resource that's going to be available. And if we get a second wave, that will certainly make things even worse. One of the constraints we've had is that many anaesthetists who might be supporting surgery were required to support intensive care as well. So I think some very, very difficult choices will need to be made. And I don't think as a country we've really experienced this in quite this way before. We're really going to have the capacity constraints of a middle-income country, but with the expectations, regulatory requirements and ways of thinking that go with being a high-income country. And that's quite a shock, I think.
Yeah.
And it's going to be...
How do you educate the population then about this, that actually they can't, the NHS is free at the point of need, but it's not going to be available to everyone at the time they want?
It is very difficult. What we've tried to do is to describe all operations by a degree of prioritisation, to make sure that everyone understands what the experts believe are procedures that can be reasonably delayed for, say, only a few days, those that can be delayed for a month, those that might be safe to delay for 3 months with minimal risk to the patient. Once you exceed the guidance that we've produced, we believe that there's substantial risk of harm, and we really have to get everyone to understand that it has to be done by clinical priority and the benefit that operation accrues to the patient. And as long as we stick to that, that's the best we'll be able to achieve.
Thank you all very much indeed.